The study I presented at SciOg, we were looking at the association between epigenetic age and the frailty index in older women with early breast cancer prior to getting chemotherapy. So this design was a secondary analysis, a cross-sectional study of the HOPE cohort, the Hurry Up Older Patients with Breast Cancer cohort. This was a cohort of about 500 women who were 65 and older with a diagnosis of stage 1 through 3 early breast cancer who were slated to get chemotherapy prior to treatment. And we looked at different measures of biological and functional aging in this patient population at this one time point. So we found that there was an association between the measures of biological aging and measures of functional aging in this patient population. So the measures of biological aging that we used was epigenetic clocks. So these are algorithms that measure the DNA methylation patterns that we see as we age. And these clocks are developed to compare biological age with chronological age. We used 3 generations of epigenetic clocks for this study. The first generation were the Horvath and Hannum clocks. The second generation was the Grimm age and pheno age clocks. And the third generation was the Dunnigan pace, which is a measure of a rate of age of biological aging measured in biological years over chronological years. To look at the first and second generation clocks, we also calculated something called the epigenetic age acceleration. So this is the residual that results from regression of the biological age is determined by the clocks over the chronological age of this patient population. So we then looked at the association between these epigenetic age acceleration markers in these women at this time point and compared it to our functional measures. Functional measures, the main outcome was the deficit accumulation frailty index, which is a measure of frailty. And this kind of takes a compilation of 50 different items of multidimensional, like physical, social, and cognitive function measures that we've collected on these patients and generated a score. And the score kind of reflects the frailty status depending on prior studies showing different cutoff points to define robust, pre-frail, and frail patients. So we found that among our patient population, about, let's say like 25% were pre-frail or frail, and these pre-frail or frail patients had significantly higher rates of epigenetic aging, age acceleration compared to those who were robust, looking at the different epigenetic clocks. In particular, the first and second generation clocks the second and third generation clocks were the ones that showed statistical significance. So those were the clocks that demonstrated those who were pre-frail or frail had increased rates of epigenetic age acceleration compared to those who were robust. And on average, one of the clocks, for example, the pheno age clock showed that these women were on average the women who were pre-frail and frail were on average 4.5 years older than those who were robust biologically, and aged at about a 10% faster pace of aging. So we showed this association, but we also saw that there was significant heterogeneity in the groups, which means that even among those who were robust, there were still some who did not have any evidence of epigenetic age acceleration. And among those who were frail and pre-frail, there were those who had younger biological age or no age acceleration. So there's still this is not a perfect correlation with frailty. There's definitely discrepancies in these different measures of aging, both biological and functional aging. So I think the clinical significance for these results really is very preliminary evidence that measures of biological aging may give us additional information on top of our measures of functional status and frailty in the clinic. This still a ways off from potential clinical translation. I think it sets the stage for future work where we look at how does epigenetic age, predict outcomes in our patients in terms of, for example, treatment toxicity or hospitalization or tolerability of treatment and even cancer outcomes potentially in the future. Until these studies are done, we can't really, and compared to how they're better or how they supplement our traditional measures of function and functional aging, um, can we add to our traditional measures to better refine the treatment recommendations for our older adults who may be more susceptible to treatment toxicities and outcomes and adverse outcomes?